Very good afternoon to one and all. So today we start off a bit late. Sorry, because of a few patients couldn't start off at 3 o'clock, but well, uh, better nonetheless. So today's topic is cervical facet pain and unknown cause of neck pain. So this is quite a very common entity which everyone faces in their day-to-day problems, especially people who are doing work from home or who use the laptop a lot on working. So cervical facet pain is one very common problem which can affect people doing that. I think even our digital team would be interested to listen to this topic today because this can be a very common cause of neck pain. All right, so moving ahead, let's have a look at the contents of the presentation today. I'll start off with a brief introduction and then followed by anatomy of what is the cervical facet joint, a bit of cervical facet pain, the management, how to treat it, and then finally the conclusion. So cervical facet pain, if you see the prevalence is very much common, especially in people having neck-related problems. No, it's called the cervical spine problem. So if you see anyone having neck pain, almost 55% there is a prevalence of the cervical facet joint pain in such people. If you go lower down, that is the thorax, which is the upper back, it's around 40%, and in the lower back, it's around 31%. So what is cervical facet joints? Well, remember our entire spinal column is divided into three main components. The upper neck part is called the cervical spine, mid back, upper back is called the thoracic spine, and the lower back is called the lumbar spine. So whenever there is a spine, there are like bones are in one over the other. So whenever the bones are sitting on top of each other, they form something called as a facet joint. Okay, and this facet joint can be a cause of pain. So the facet joints are found by articulation between superior and inferior articular processes of the two adjacent vertebrae, and they are angled at 25 to 35 degrees in the caudal direction. So basically, each facet joint, whenever it is there, there are certain nerves which are there around the facet joint. So why are nerves present in our body? They are present to take the painful signals from that particular joint and go and supply to the brain, telling that there is pain coming from that particular facet joint. So if you see this diagram, you can see a certain patterns. So you can see some numbers over here, C2, C3, 3, 4, 5, 6, 4, 5, 6, 7, etc. So this is the pain distribution pattern, depending on which facet joint has got involved. If you see the upper neck, side of the neck, upper back near the trapezius region, many of the time people get pain when they are sitting in front of a laptop or working for a long time, or even looking at the mobile phone for a long period of time. So what happens is these areas can develop pain either because of a muscle related spasm. Many of the time we think it's a muscle spasm, neck has got stiff, and we just ignore it. But remember, even a facet involvement can present like this. So what is a cervical facet pain syndrome? It's a combination of symptoms. There is neck pain, midline neck pain, and then whenever you apply pressure over that particular part of the neck, there would be pain, difficulty in movements, limitation of extension, rotation, etc. So what is the differential diagnosis? What do we mean by differential diagnosis? These are other entities which can have similar complaints. One is myofascial pain syndrome or a simple muscle spasm. A cervical radicular pain usually occurs due to cervical disc, slip disc, which presses on that particular nerve. And other things can be injury to the cervical spine, strain, injuries, etc. Right. So moving ahead, how do we manage these problems? One is conservative, other is interventions. Conservative means medications, painkillers, muscle relaxants, which usually help. Physiotherapy, stretching also can help. Exercises help in strengthening your neck, and multidisciplinary treatment. So coming to intervention, see, usually when someone comes to us with pain, neck pain, and probably if the pain is not reducing with the tablets, medications, or it is not reducing with the physiotherapy exercises, then we go ahead with something called interventions. Now, what do you mean by interventions? Interventions are something which are nothing but the injections. So there are quite a few injections which are there. namely two famous injections. One is called the cervical medial branch block, and other is called the cervical facet intra-articular injection. Medial branch block, again, there are two types. One is a diagnostic block, other is a radiofrequency ablation. Let's concentrate on the medial branch block now. There's something called the diagnostic and then a radiofrequency ablation. So we'll go ahead first with how we do this particular treatment. Okay. Now, this is how we do under the X-ray machine. This is a fluoroscope and this is a lateral view. So what you are seeing over here is a lateral view of the cervical facets, wherein you can see the vertebrae, bones arranged one over the other, and then you see the articular pillars and the disc in between and the spinous process. Okay. So important thing is getting something called the true lateral view. Now, right. So how do you get a true lateral view? Distance between the posterior laminar line and the posterior aspect of the articular pillar must be greatest. Facet joints above and below the level of interest must be crisp. Disc space is clear. Anterior and posterior tubercles on each side should form a superimposed curvilinear line, as you're seeing in this figure, the red colored line. Now, so once you obtain, you take a lateral view. So you insert, so this is basically the lateral approach, right? So in this, patient is usually supine, and then once you image this, given skin local anesthetic, we are going to take the spinal needle and then target the articular pillar. So what you are, let me just annotate this a bit. Okay. So here what you are seeing is, this is the articular pillar. This structure, what you're seeing, this is the articular pillar, and this is the spinal needle, which is going into the center. This is going to be a final target point, right? The other things, okay, this is the vertebra, all right, and then this is the spinous process. Clear? Okay. Right. So what are the advantages? This is the lateral approach. Remember, shorter needle track, less patient discomfort than the posterior approach and easy patient position because patient is lying supine. Disadvantages, you have the spinal cord in the needle trajectory, you have vital structures. So, and parallel placement for a medial branch is not possible. Right. So let's go to the posterior approach now. Remember, posterior approach, patient is in prone position. Identify middle portion of the articular pillar like this. What you're seeing over here is this is the posterior approach. Okay, let me just annotate this a bit. So what we are seeing over here is, remember, this is going to be the articular pillar. So I've drawn over here, this is the trough region, which you have to target. Take the needle and then hit over here. And once you have hit the bony contact, you've made a bony contact, then slip. Okay. So again, remember, this is the PA view. So these are the vertebrae, spinous processes, the vertebrae again, spinous processes, and this is the disc. Clear? All right. Let me undo this. Moving ahead. In lateral view, again, you have to reach the centroid of the articular pillar. Right. So for diagnostic block in lateral view, advance the needle towards the center. And remember, you're going to inject 0.3 cc of local anesthetic only. For RF, you use an RF cannula. Little bit more ahead compared to the diagnostic block needle, you're going to take the RF cannula. And once you've reached the exact spot, remember to do the stimulation, sensory and motor. Once you've got the adequate stimulations, you're going to lesion at 80 degrees Celsius for 90 seconds. So here you can see we are doing the RF ablation. Advantages, it's safe, no vital structures in trajectory, allows parallel placement of the RF cannula to the medial branch. Disadvantages, longer needle track, more patient discomfort than the lateral approach, and it's more difficult to overlap articular pillars from opposite sides than in the lateral approach. So here's me doing cervical facet radiofrequency ablation. I did a diagnostic block for the patient, and patient had more than 75% of relief. So I decided to go ahead with the cervical facet, middle branch, RF. Here you can see my needle. Okay. This is the PA view. And over here, you are seeing the facet, and needle is in the middle of the centroid of the articular pillar. Right. So ultrasound guidance is very popular now. This is the era of ultrasound in the field of pain medicine. So cervical facet medial branches can be safely, effectively, and efficiently accessed with the ultrasound guidance. Remember, a diagnostic block is easier to do with ultrasound, but RF, you have to use a fluoroscope guidance. So here we use the out of plane technique. Patient is in lateral position, and we use a linear transducer. So this is how the patient will be in lateral position. And over here, let me just annotate a bit. Okay. What we're seeing over here is you're seeing a wavy pattern, right? So remember, the troughs is going to be the target. This is the articular pillar. Okay. Here is going to be the target. So you're going to take your needle in ultrasound out of plane, come till here, and then you're going to chain the probe, tilt the probe, see that you're going to reach the center of the articular pillar. So this is the in-plane conformation, articular pillar and then the needle on top. Okay, so here you can see, this is the, let me annotate this a bit. This is the vertebral artery. Okay, remember the pulsation. This is the spinal nerve root, and this is the medial branch of interest. Here is going to come your needle from here and target the medial branch. Clear? All right, so here is a video. You can see this is the medial branch. You can see the needle coming slowly. We're seeing the wavy pattern over here. And here you can see the needle coming in. Okay, in the center. There. Now this is in the lateral view. We're seeing the needle trajectory coming in on the articular pillar. So remember, complications we always have to keep in mind. What are the complications? Vertebral artery involvement. The needle goes and hits the vertebral artery. The patient is going to have a seizure on the table, stroke, etc. Injection of spinal nerve root can lead to nerve damage, intrathecal injection. Again, spinal cord infarcts, infection, bleeding, allergy, etc. So medial branch blocks versus intra-articular injections. Remember, medial branch blocks have a positive recommendation, whereas intra-articular have a negative recommendation. So for a beginner, medial branch blocks are always better to start off with. This is the evidences what we are seeing. You can see cervical facet pain, the therapeutic injections, medial branch 2B plus, whereas RF to C plus. You can see, and if you see, there is level 2 evidence for the cervical facet injections. Hybrid technique is what I usually prefer if I'm doing an RF. So here you can use both fluoroscopy and ultrasound. Intra-articular injections, again, just for theoretical interest, I've kept. Over here, remember, you are just going inside the facet joints. The posterior or lateral approach can be done. I usually don't prefer doing the intra-articular injections because of the complications, and they have a weak against or a negative level 4 recommendation. Well, to conclude, cervical facet pain is often misdiagnosed. Remember, it can be a difficult thing to diagnose. You can get confused with the myofascial pain syndrome, etc. But for neck pain, facet joint involvement has to be ruled out. And for people doing the procedure, remember, a hybrid technique using fluoroscope and CM is the best. Thank you very much for your patient hearing. I'm done with the presentation. I'm stopping the share.
Yeah, yes, doctor. Thank you, doctors. If someone has some doubt or something.
Does anyone have any doubts? I'm just stopping the screen share. I'll go back to the Zoom. Does anyone have any doubts? That means no one is having any doubts. But okay, to conclude with, I would say that remember, anyone having neck pain, don't just dismiss it off saying that it's only a muscle spasm or anything like that. It could be a cervical facetogenic involvement. Whenever you have pain, always take your time to get it evaluated, visit your nearest pain management specialist, and evaluate your pains and lead a pain-free life. Okay, thank you very much for your patient hearing.